So today we're so excited to have Kristen Beckler here today to share her wonderful knowledge about the world of child life. I know she has some amazing content to share with you all. She has been our instructor for over 5 years now at UC Santa Barbara, and she is currently at UC San Francisco Hospital as a child life specialist. And, Kristen wears many hats, and today she's going to share with you her knowledge as, how to best prepare you guys for internship and just the world of child life. Kristen, it is so honored to have you here to share with our students your amazing knowledge and information and insight into the child life world that so many of our students just are really hoping to get there. I know you guys are all on the right path of becoming a child life specialist. So let's hear what Kristen has to share with us today.
So like she said, I'm Kristen Beckler. I work at UCSF. My job right now, I'm an outpatient child life specialist. So I work in an anesthesia clinic helping kids prior to coming to the hospital prepare for anesthesia. I also work with our Comfort Promise program, which is a new initiative aimed at reducing needle pain in pediatrics. And I'm also the student program coordinator at UCSF. So I am all things students. I'm really involved in our student program. I manage our practicum as well as our internship. So there's a very good chance that you are going to be asked, so you're on an elevator and you're on the ground floor. Somebody gets on the elevator with you and says, hey, child life, what is that? It could be a doctor, it could be another parent, it could be a kid. How do you explain in 3 floors what a child life specialist is? So what I have done and what I did when I first became a child life specialist and I wanted to kind of create my own elevator speech, I started kind of picking out keywords. What are the main things I do? I can get rid of all the rubbish around it. And so I kind of highlighted some of the things that I noticed in this big statement that the Child Life Council, or that's the old word, Association of Child Life Professionals says. So we're educators. We focus on patient and family care. We focus on trauma and reducing trauma, right? We want to teach positive coping techniques, the stress. We want to work with stress and helping children cope with the stress of being in the hospital. We have so many interventions that we provide. We do play, preparation, education, developmental support, and advocacy. My elevator speech, since we're all have gone, is my job is to help reduce trauma associated with being in the hospital. And I do that through preparation, coping techniques, education, and play, period. And I adapt that saying to all the ages. That is the same elevator speech I have had for 22 years, and I don't change it. Infants, children, and youth communicate their needs through words, play, and behavior. We're committed to enabling all forms of communication. We accomplish this by observing, listening, facilitating communication with those who may be misunderstood or needing support in order to be heard. Written documentation of child life specialist interventions and evaluations of outcomes is an essential aspect of our practice. Charting is the bane of my existence, but we have to do it, is the moral of that. So our goals in healthcare, communication feels like such an obvious part of child life, yet we're kind of this small, powerful force in pediatric care. We're part of the child life team. We're also part of the interdisciplinary team for the unit that you're on. So we want to make sure that we are really have some strong goals with our communication. So we want to make sure that our healthcare providers are taking the time and have the skills to talk with children and families. We do a lot of education in child life. Children need to understand how, we need to help people understand how children are receiving and interpreting information. We want to be able to share and collaborate with that medical team and family in a way that everybody can understand. And of course, as advocates, we're constantly translating information for kids. And the reason we're constantly doing that is because kids just don't understand what medical terminology is. We always want to use language that is clear versus that very ambiguous language. When you say to a kid, you need an IV, good chances they're thinking you're talking about something outside. I need to flush your line. If a nurse walks in and says that to a child, what flushes? A toilet. They're not thinking about the IV that's in their arm. We're taking you for a CAT scan. Oh, look at that poor little kitty, so cute. This is often what kids think of when you say the word CAT scan. They think that you're doing something with animals, and then they get very disappointed when you don't bring an animal by. I can't imagine the disappointment when they see that CAT scan machine versus not having a cat. So clear language versus that ambiguous language. So when you are helping kids get nice and confused, When you're thinking about giving kids anesthesia, calling it gas, calling it sleeping medicine or gas or sleeping gas, put under, knocked out, or we're going to put you to sleep. Those can be very unclear words to kids. So when we're explaining anesthesia, we always say you're going to get it's a medicine sleep. It's different than nighttime sleep. It's not like when mom comes wake you up. There's a doctor that watches you the whole time and gives you a little mask to breathe so you don't feel anything during your surgery or remember anything. Also very confusing is the PACU. And if you're not familiar with the PACU, that is like a post area after anesthesia, after when you're waking up. It's the recovery room. If you look in the clear terminology over here, we call it the recovery room. Kids don't know what a PACU is, but that's what all the medical doctors call it. They're like, you're going to go to the PACU afterwards and recover. Take you to the floor. If somebody's down in the emergency department, and we're going to take you to the floor, that doesn't mean a lot of things to people. We're just going to take you to the hospital bedroom. We're going to take your blood pressure. Again, that doesn't mean anything. We're going to measure, we're going to check your blood pressure. You hear a lot of people say, we're going to give your arm a hug with this blood pressure cuff. It's a tight hug. It might make your fingers feel a little tingly. Soft language versus hard language is another thing that we spend a lot of time. And if you've taken theory, hopefully you've had a lot of this exposure to some of this language. Hard words, pain, it's going to hurt, it's going to pain, or there's going to be pain. I hear a lot of doctors say, oh, it'll feel like a bee sting. Well, there's nothing in the universe that feels like a bee sting except for a bee sting. They really burn. And so I would never recommend. And so I usually correct medical staff when they say it feels like a bee sting. Softer language is it's going to be a little sore. You're going to feel a little pressure. It might feel a little uncomfortable. Some kids say it feels a little scratchy. The word burn in this situation, when I think about this is when you put in numbing lidocaine sometimes, for especially the kids getting stitches, that it does burn. Usually, there's not really a way you can buffer the lidocaine, but it still burns a little bit. Often we describe that to children as it's a warm, it feels really warm. It's going to feel kind of hot for a second. Another hard word, cut, open, slice, hole, anything to think about with going to the operating room. The doctor's going to make an incision. They're going to be a small opening. Using the words like shot, poke. It sounds like a gun. I had a teenager actually in the youth advisory. Oh, somebody's not muted. Somebody actually, because we were talking about the word poke and whether or not we should use that word anymore. I don't really use I call everything, I call it what it is. If you're having a blood draw, you're getting a blood draw. I don't typically use the word poke. It's not something that's in my language, but a lot of child life specialists do still use it. But I actually had a adolescent tell me the other day, she said, well, when doctors say, or nurses say, it's just going to be a quick little poke. Blood draws and IVs aren't quick. Sometimes they have to look for the vein. Sometimes they have to search around in there. And so she said, when they say it's going to be a quick poke and it's not quick, it makes me feel like they've lied to me. So again, I just always encourage people to say what it is. If they're going to have a vaccination, call it a vaccination. And that is usually in and out. They might feel a little bit of the burn or pressure. Hopefully you can use numbing cream so kids don't feel much of anything. But again, just call it what it is, or some kind of needle procedure. Telling kids like bad tasting medicine. Some kids, the medicine doesn't always taste bad. So it's just a medicine that tastes different. You tell us what you think it tastes like. Keep it really simple. The familiar language versus unfamiliar language. Unfamiliar, an incision is going to be really an unfamiliar word to children. So just to continue to use a small opening, we saw a picture of that IV branch in the woods compared to an actual IV. With kids, I usually say an IV stands for in the veins and show them on your skin the blue lines. And we're going to slide a little straw underneath your skin so we can give you water and medicine to help your body feel better faster. Anesthesia, not Anastasia. I've had so many kids ask if we're going to watch that Anastasia movie, which is kind of an old Disney movie. And again, just like the CT scan, you can't even imagine their disappointment when you roll them into a surgery suite and we're not watching movies. So I'm being very clear on what anesthesia is. Anesthesia is a medicine that you breathe. Older kids over the age of 13, we would prepare them for an IV. so that they could have their anesthesia through an IV. It's safer for older and larger kids. So again, we would not do air anesthesia for an older child. CAT scan, CT scan, it's just a big camera that takes your picture. You'll hear a lot of child life specialists say things that looks like a big donut hole. Sometimes they're just comparing it to something it might look like. Because a CT does look like that, and an MRI looks more like a tube. That's a very long procedure. We won't get into the details of that. A stretcher, kids get very confused by the word stretcher because they think you're actually physically going to stretch them. So we just say it's a bed on wheels, or call it a gurney, which is a bed on wheels. So those are just a few examples of, just different language things that, can kind of trick kids a little bit. So what is family-centered care? Again, briefly, it's an innovative approach to the planning, delivery, and evaluation of healthcare that is grounded in mutual benefits and partnerships amongst all those people. So the Institute for Patient and Family-Centered Care really believes if you keep these core concepts in the back of your mind, it'll really help better health outcomes and improved experience for patients. It could have even better staff satisfaction, and just a smarter allocation of resources. So as long as you're working with respect and dignity, sharing information in a way that people can understand, offering opportunities to participate in a way that they're comfortable participating in, and then that collaborative nature, working with the family to create a solid foundation for the children in the hospital.